I truly feel fortunate. And I say this in clinic all the time. I say this to colleagues all the time. I think I said it last night to one of the fellows. Like, I feel so fortunate to be in this space at this time. I think that, it would have felt very different 30 years ago, 40 years ago, where we were really just, and even 5 years ago, when we were really, right, we were really just stuck with medications that were devised for other disease processes, and we were using as, ways of mitigating symptoms to try to improve day-to-day quality of life. Whereas now I think the tools that we have seem to have fewer day-to-day side effects. So affect day-to-day, quality of life less poorly in terms of the side effect profile of the drugs, like other medications, beta blockers that can really cause a lot of fatigue, sexual dysfunction, things that can be really important and life-altering. These medications don't seem to do that, and also offer all of this benefit in terms of actually reducing the burden of the disease in and of itself. I think it's not just about the myosin inhibitors. There's a lot of work and thought that's being put into the SGLT2 inhibitors and whether or not those can be disease modifying. There are a lot of people thinking about and trying to understand, the same way that myosin inhibitors were developed. You have to understand how these genetic abnormalities then result in proteins that have malfunctions. And if you can understand the malfunction, then you have a way to target that malfunction and try to correct it. And I guess that's the most exciting thing to me about this whole disease process is, like, if you think about, the work that the Seidman lab did and, leading up to their discovery of the first genetic change that's responsible for HCM back in the 1980s when I was in elementary school, and where we are now, that is all led from the work that was initially started, and just thinking about that stepwise process. It's really the process of scientific discovery and then turning that over into how can we help is just really fascinating for me to witness. That was very long-winded, but that's truly how I feel about it.
It's a great question. I guess, what I'd say is that you're correct. There's been a huge explosion in cardiomyopathy treatments with novel agents. Just to be clear, I do think that it's important to recognize that prior to this, over the last prior 50 years, we have had a lot of work put into evolving other treatments that have also made a huge impact on patients with this disease, both medically and invasive therapies. This, though, does represent, meaning this current era of new therapies, does represent, I think, an incredible shift upwards in providing what hopefully will be many more additional options for patients with hypertrophic cardiomyopathy to achieve the goal that every patient wants, which is a great quality of life with normal longevity. And I think that's what we're looking at here, more options to be able to do that than we've ever had.
It has been extremely rewarding because finally, after all these years, we are getting to a point where we are focusing on individual entities with a common pathophysiology and a common phenotype. It is really not satisfying and unlikely to be successful when we keep lumping large phenotypic presentations and indications and try to find a statistically significant result. Here, you're focusing again back down on the individual disease entity and trying to influence the outcome. So that leads you to working better with patients, working more closely with patient advocacy groups, with sponsors, and having, more, kind of being more excited about what the future holds. And honestly, it's been incredible. I've started working on this since I was a trainee, and I would never have imagined that we are getting to a point where we are thinking about not just a specific indication for a cardiomyopathy disease, but we're thinking about a specific gene within the specific cardiomyopathy phenotype. And hopefully we'll get a stretch of positive outcomes and positive results, because if we do, then that's going to keep the momentum going. And ultimately, this is where we can influence tremendous amount of we can influence how the disease progresses in some patients, and we can influence how we are treating not just an individual patients, but also families. And then finally, this concept that we have to focus on the individual specific disease have also fit into the genetic evaluation component, which is largely missing in the United States. If you look at on average, only 1 to 2% of patients with disease get genotyped, for example. And despite all the guidelines, despite everything that's saying that should not be the case, I think finding specific therapies and focusing on this specific population will now create an incentive for everyone within the cardiology community to start and thinking about these genes and genotyping patients and helping their family members as well. It's not just a singular, essentially, person that you're taking care of. It's the whole family sometimes.